wanted to focus on more of, the future of MDS treatment or questions that we are trying to answer in the field of myelodysplastic syndromes. So, as the audience know, myelodysplastic syndromes are a heterogeneous group of neoplastic stem cell diseases. So those are blood cancers. They are clinically characterized by bone marrow failure with cytopenias and the resultant complications. Nowadays, we can demonstrate evidence of clonality in almost 90% of the patients. And in general, myelodysplastic syndromes are actually probably the most common myeloid malignancies. The average estimates are roughly around 50,000 cases per year in the US. It's a disease of the elderly, so the average age is 70. When we look at all the MDS patients, around 30 to 40% of them will progress to acute myeloid leukemia. However, unfortunately, also 50 or 60% of the patients with MDS will die from complications related to the disease, namely cytopenias, or the interaction or the interplay with other comorbidities. In the past, we used to really struggle because MDS was not considered a cancer by the registries, which we know for sure it is. Nowadays, that's been fixed in a way. And the name is always almost a misnomer because dysplasia is a morphologic description of the abnormal looking cells. It's not a precancerous description. And we think that there are obviously cases undiagnosed because anemia is common in elderly, and MDS is actually one of the top 5 causes of anemia in older population. Now we've made some progress. So obviously MDS was recognized years before as a pre-leukemia and then evolved at its own category. I think clinically the important landmarks are shown here. In the 1997, the first classification or prognostic scoring system was proposed. It's referred to as the IPSS, or International Prognostic Scoring System, where you really estimate the risk of the disease, and the goal is to tailor the treatment based on the risk of the disease. Then in the early 2000s, we got first drugs approved for myelodysplastic syndrome, hypomethylating agents, 2 drugs, azacitidine, decitabine, and then lenalidomide, particularly for patients with a certain cytogenetic abnormality called deletion 5q. And then we went into this drought of really no further drug approved till last year or the year before, where we got Luspatercept, which is a drug used for treating anemia in a subset of lower risk MDS patients. And the decitabine that we've used for several years became oral medication that can be available for patients. However, in between, we really had revolutionized the way of understanding of the disease because of the advancement in technologies such as the ability to look at gene mutations and understanding the molecular biology of the disease. This year, there was the first proposition for a revised scoring system called International Prognostic System Molecular. And the WHO is working on reclassification of MDS, integrating all this molecular information we learned in the last few years. Now, obviously, MDS is diagnosed by clinical history. Patients will have low blood counts. You exclude nutritional deficiencies, other abnormalities. And finally, patients will get bone marrow aspirate and biopsy. It requires an experienced hematopathologist to demonstrate either increase in the myeloblasts, but below the threshold of leukemia, so 5 to 20% blasts, or what we call the dysplasia, which is the abnormal looking cells, where they count 200 cells of each cell line. And if 10% or more are dysplastic, that's called MDS. And nowadays, sometimes by certain cytogenetic abnormalities, we can call the diagnosis. It's important to emphasize that one should spend time, making sure that the accurate diagnosis is made. In our experience and data published from our colleagues in MD Anderson, in around 20 to 30% of the cases, we change the diagnosis, either mostly upstaging the patients, but we've seen, unfortunately, patients labeled as MDS and treated for many years, and they did not have the disease. So it's crucial to spend some time making the diagnosis. Then the next step is really the risk stratification with what I refer to as the IPSS or the IPSSR, because obviously this is important information for the patient. prognostically, but you tailor the treatment, and namely thinking who we are going to think for, sending to allogeneic stem cell transplant based on the disease risk. So all those risk scores are basically similar in a way that they integrate certain clinical features: the percentage of the myeloblasts, the degree of cytopenia on the bone marrow, and the degree of cytopenia, and the cytogenetic information. And you get a lump score, and you divide the patient into 1 out of 5 stages. We refer to them as very low, low, intermediate, high, and very high. You could think of them as stage 1 to 5. And you look here, if somebody is really a very low risk, their average survival is around 9 years. While if somebody is a very high risk, the average survival, unfortunately, for those patients is less than a year. So I always like to bring the comparison that a higher risk MDS is really probably associated with worse outcome than some of the metastatic solid tumors that we think of. So for patients that are in the high and very high risk, and sometimes in the intermediate risk, we start, thinking of allogeneic stem cell transplant up front for those patients.